Now let's move into the first event of the day, which is the CME presentations. Before I introduce our speakers, I would like to cover a few housekeeping topics. So this is a webinar, so if you have any questions or comments during the presentations, please use the Q&A chat box to text your messages. I will pass those questions and queries to the presenters at the end of the end of each presentation, so then we can have a good discussion. If you have any concerns, if you want to say something, please raise your hands as well. And each presentation will go on for 15 minutes. And then we will have about 5 to 10 minutes of discussion time. Finally, please keep your mobile phones on silent mode. Let me introduce our first speaker, Dr. Malathi Sivakumar. Malathi is very well known in Sydney suburbs. She's a very busy general practitioner for the last 25 years in Sydney. She is from the second batch of Jaffna Medical Faculty. Apart from his general practitioner training, she's a fully qualified ENT surgeon from Sri Lanka. She volunteers to visit Sri Sathya Sai General Hospital in Prashanthi Nilayam, Andhra Pradesh in India to operate twice or 3 times a year before the COVID era. She has been doing this volunteer service for the last 22 years. She also has very good ties with the Sathya Sai Center in Australia. And she's the National Medical Coordinator for Sathya Sai organization and Sai spiritual educator as well. I will now invite Malathi to share his screen and do the presentation. Thanks, Malathi. Over to you.
Thank you, Sudeshan. I'm sorry for the delay. Good evening, everyone. We were all supposed to be in one room, but it seems like COVID has foiled our plans once again. Maybe God has his own plans. It is a privilege for me to do this presentation in the presence of our Professor of Medicine, Professor Sri Haran. He was also my boss during my internship in the professorial medical unit. Iron deficiency anemia is bread and butter for us, the primary care physicians, but it is always good to go back to the basics and refresh our memory. I promise you, I will be short and sweet. Disclaimer, there is no personal sponsorship. Can I have the poll questions, please? Just a few questions for like an icebreaker session. The first question, anemia affects what percentage of the world population? Can you please answer either A, B, C, or D? Please respond in 20 seconds. You can stop the poll. Yeah, 30%. Yeah, fair enough. But the 30% is okay, but the latest study in 2021, WHO has suggested that 20% of the population has iron deficiency anemia. The second question, please. Iron deficiency anemia can cause pica, a rare condition in which a person craves for various items. Which of these would he or she eat? Either ice, soil, clay, or all of the above. Please respond within 20 seconds. Close the poll, please. Well, good. All know all about iron deficiency anemia, I guess. The third question is just answer in the chat box, please. What do you call a person who is deficient in iron? Just please respond within 30 seconds. There are no responses. Nick, and deficient. Fair enough. I thought I could add a joke here. So you will see the answer. But this applies to us, the iron women too. Thank you all for your response. I hope you would have understood the joke. Now coming to the topic, iron deficiency anemia is the most common mineral or nutritional deficiency anemia in the world. And according to the WHO classification, the 80% of the world population suffers from iron deficiency, and 20% of the world population has iron deficiency anemia. Iron deficiency without anemia is more common. In Australia, 8% of preschool children, 20% of the pregnant women, and 15% of non-pregnant women of reproductive age are affected by anemia, with iron deficiency being the major cause. Definition of iron deficiency is low serum ferritin, less than 12 micrograms per liter in adults is classified as iron deficiency by the WHO. But less than 30 micrograms per liter has high sensitivity and specificity for iron deficiency, correlating to the absence of iron stores in the bone marrow. Anemia is considered as less than 130 grams per liter of hemoglobin in males, and in females and elderly, hemoglobin of less than 120 grams per liter is considered as anemia. 70% of the iron in adults is found within hemoglobin. So anemia is the most recognized effect of iron deficiency. In pregnant women, the level of hemoglobin for anemia differs in different trimesters. So coming to the signs and symptoms of iron deficiency. Iron is needed for several metabolic pathways and it is responsible for the carriage of oxygen to all body tissues. Therefore, iron deficiency anemia can cause a variety of symptoms. Tiredness is the most common symptom. They also may present with low energy, weakness, fatigue, reduced exercise performance, dizziness, and another common one is increased hair loss, difficulty in concentrating, poor work productivity, headaches, and the list goes on. And you might notice pale skin or gums, brittle nails, and poor neurological outcomes in infants born to mothers with iron deficiency. And if the iron stores are low and in early stages, there may not be any symptoms at all. The causes of iron deficiency anemia, it's back to basics again. Any scenario that reduces ingestion or absorption of iron or increases the blood loss can lead to iron deficiency. The common causes is firstly is the inadequate iron uptake. In the inadequate nutritional iron intake may be due to low dietary iron content. For example, in vegetarians or the vegan diet, but I, being a vegetarian, still managed to maintain my iron levels. But even non-vegetarians, if they are not taking enough meat, they also can be iron deficient. And the second cause is food insecurity or low dietary diversity, for example, resulting from poverty or especially in the low-income countries. The increase in the iron requirement, like in pregnancy, breastfeeding, athletes, or if somebody is frequently donating blood. Then inadequate nutritional iron absorption, when the concomitant consumption of iron inhibitors like calcium, tea, coffee, and oxalates and phytates in the plant-based food. Then inadequate stomach acidification, as in atrophic gastritis, use of antacids or proton pump inhibitors, Helicobacter pylori infection, and gastric bypass surgery, as in bariatric surgery. Another cause is intestinal mucosal dysfunction, as in celiac disease, Crohn's, and inflammatory bowel conditions. Now, coming to blood loss, the commonest form of blood loss in girls and premenopausal women is gynecological problems, which will be dealt by Dr. Ablation after me. If we look at gastrointestinal tract, the commonest causes are from the bleeding from the esophageal varices, gastric or peptic ulcers, neoplastic conditions such as colon cancer and gastric cancer. And we also have to be mindful about the drugs we use, such as antiplatelets, aspirin, anticoagulants, and all NSAIDs, and vascular malformation, angiodysplasia, and hereditary hemorrhagic telangiectasia. In the anal area, hemorrhoids, frequent bleeding from the hemorrhoids can cause iron deficiency anemia too. And in the developing world, parasites like hookworm. And in the respiratory system, severe hemoptysis in lung cancer or infections and recurrent epistaxis can cause anemia. and in urinary tract, such as hematuria from renal or bladder cancer, and urinary cysticercosis. A brief lines on physiology of iron absorption. Physiological demand is the strongest stimulant for iron absorption, and usually the pH of the gastric acid helps in the conversion of ferric iron to more absorbable ferrous iron. This is achieved via ferric reductase enzyme using intracellular ascorbate, the theory of how vitamin C can be of help in iron absorption. Also, once inside the enterocyte, the ferric iron is converted to ferritin and it is stored in the cells. And hepcidin regulates iron absorption by binding to the ferro portion. Now, diagnosis of iron deficiency. Mainly the primary care physicians, they help, they play an important role in the diagnosis and management. And recently the Vitaris conducted a survey, and in that 2 out of 3 people have who had been previously diagnosed with iron deficiency wished that they had seen their GP sooner. And 4 out of 5 people agree that being recommended the correct treatment for iron deficiency by a professional is important. So that for the diagnosis, the main test is the iron studies. And in the iron studies, to differentiate between iron deficiency anemia and the anemia due to chronic disease, the iron will be low in iron deficiency, and in anemia due to chronic disease, it may be low or normal. The transferrin saturation, it's the same, but ferritin will be low in iron deficiency anemia, but it may be normal or even high in anemia due to chronic disease. And again, transferrin will be high in iron deficiency anemia, but low or normal in anemia due to chronic disease. Soluble transferrin receptor is again a valuable indicator to differentiate between iron deficiency anemia and anemia due to chronic disease, but it is not Medicare rebatable. But ferritin being an acute phase protein, it may be raised in inflammatory conditions and in elderly, which makes the diagnosis of iron deficiency a challenging one. Therefore, the level of or threshold with low transferrin saturation may be used, and the ferritin level will be high. So for example, in inflammatory conditions, the ferritin level of less than 100 is considered as iron deficiency. And in heart failure, less than 100 micrograms per liter, or the ferritin of 300 micrograms with less than 20% of transferrin saturation is considered as iron deficiency. And in kidney disease, less than 500 micrograms of ferritin and 30% of transferrin saturation is considered as iron deficiency. Now the next slide, I think it's too crowded. I will skip that slide because of the time. And again, this shows different kinds of anemia and the levels of the ferritin and the hemoglobin levels. So now coming to the management, the cornerstone of management is twofold. One is to investigate and treat the underlying cause, and secondly is to treat the iron deficiency. Management, first thing is dietary. Diet alone is generally not adequate to replace iron stores in a patient who is diagnosed with iron deficiency. But in the diet, the heme iron is mainly meat-based sources of iron. Example, and plant-based sources contain non-heme iron and are harder to absorb. Examples, dark green leafy vegetables, tofu, legumes, nuts, dried fruit, and iron-fortified cereal, quinoa, and wholemeal bread. And this slide shows the recommended daily dietary intake in children and in adults. But in adult male, the daily intake should be 8 milligrams. And in adult females, it should be 18 milligrams. And in a child, it should be between 8 and 15 milligrams. And in lactation and pregnancy, it increases. And this slide shows the iron-rich foods with how much is in each food. Then and some food elements can enhance or inhibit the iron absorption. Generally, the oxalates present in spinach, beans, nuts can inhibit the iron absorption. Calcium inhibits both heme and non-heme iron. And also the polyphenols found in black and herbal tea, wine, legumes, and cereals. This also can inhibit the iron absorption. But vitamin C overcomes the effects of dietary inhibitors. So this slide shows the different form of oral iron available in Australia. The commonest one which the TGA approves is the ferrous sulfate, which has been listed first over the iron polymaltose. So ferrous sulfate is presented in ferrogradimate or ferrograd C, and FGF and the other products are also available. But as you can see, the elemental iron is about 105 milligrams. That's the highest amount in ferrograd C or the ferrogradimate tablet. And the next one is maltopher or polymaltose. That's around 100 milligram. But to improve the gastric tolerance, the ferrograd, the modified release tablets, they help with the to help with the side effects. And we also have to be mindful about the over-the-counter preparations. But as you can see in this slide, ferrograd C has 105 milligram, but at the same time, Nature's own tablet has only 5 milligram tablets. So now the ferric versus ferrous sulfate may be more effective than the polymaltose tablets. And the side effects of iron compounds can be nausea, epigastric discomfort, bloating, flatulence, constipation, diarrhea, and so on. But modified release formulation can be helpful with gastric tolerance. That's the ferrograd C. And the next is IV iron. when that is indicated. So if somebody is not responding well to oral iron, or if there is impaired absorption, and if the iron supplements are poorly tolerated, or when there is rapid restoration of hemoglobin is needed, when, as in acute blood loss, or like a pre-op surgery, urgent surgery, and in some conditions like inflammatory bowel disease, heart failure, and in chronic kidney disease. In pregnancy, the oral parenteral iron is restricted to second and third trimesters. And the duration. So oral iron therapy usually should be continued until the iron stores are replenished or the serum ferritin concentration is normal, which is, it's usually 3 to 6 months. And in summary, cornerstone of management of iron deficiency is to treat both the cause and the iron deficiency. It is better to recommend a first-line ferrous treatment and recommend modified release formulation to assist with gastric tolerance and adherence. Ensure appropriate counseling is given to the patient regarding iron supplements, including the length of treatment. And these are the references. And just to reminisce the 40th year reunion at the Jaffna Medical Faculty, I thought that I'll share these 2 slides. These are a few of my batchmates with Professor Sriharan here, and Dr. Mrs. Ganeshamurthy are also in the picture. And this is again at the faculty just after the CME presentation. Thank you for your patience and listening.
Thanks, Malathi. Thanks for revising those basic bread and butter stuff in anemia, which is a day-to-day management or the clinical problem for many of the GPs. Because of the time factor, we will be having the discussion at the end of both presentations. Before we move on to the next one, once again, thanks, Malathi. As a token of appreciation, we will be giving a small a gift, and that you will see that on the screen now. Yep. Malathi, we will somehow send it across to you. Okay. Thanks again.
Thank you, Sudeshan.
Now we will move on to our next speaker, Dr. Anbu Anbalagan. He's a consultant obstetrician and gynecologist in Sydney. He's from 13th batch of Jaffna Medical Faculty. He practices at Westmead Public and the Westmead Private Hospital. Anbu has wide range of experience in minimal access surgery in gynecology. And he's a training supervisor for Westmead Hospital and the training director for Australian Gynecology Endoscopy Society at Westmead. Over to you, Anbu.
Thank you, Sudeshan. Thank you for the introduction. Thank you for JMFOA for requesting me to present on this forum. I'll share my screen now. So there will be a fair bit of crossover between Malathi and myself. Please apologize for the crossover. And if someone there in the audience, they're like me, I may have to listen to 2 or 3 times the same thing for me to understand. So that will help enormously. Okay, so my topic is iron deficiency anemia, a gynecological and obstetric perspective, but I was starting with the financial disclosure. Viatris is a company that's sponsoring, co-sponsors of our meeting. They provided with this slide, and like Malathi mentioned, that Ferrobret C is a iron tablet that they produce. So iron deficiency anemia, my definition goes as iron deficiency and then anemia. Iron deficiency is ferritin level less than 15 nanogram per liter. Anemia is a hemoglobin concentration below a certain level for the age, gender, and in a state of pregnancy. WHO defines the anemia as hemoglobins less than 130 gram per liter for men and 120 gram per liter for women, and less than 110 in pregnant women and preschool children. At Westmead, we have a guideline for the first trimester. We accept up to 110 as normal, so less than 110 is anemia. And if it's a second trimester or third trimester, up to 105 is normal. If they're less than 105, then they're anemic. In postpartum state, similarly less than 100. Then we further classify into mild, moderate, and severe anemia, where mild anemia is 90 to 110 gram per liter, moderate anemia is 70 to 90 gram per liter, and severe anemia is less than 70 gram per liter. And this slide is already has been presented in a different way. What we are looking at mainly today is iron deficiency anemia. Like Malathi said, hemoglobin will be low and serum ferritin level will be low. And if you look at the transferrin level and total iron binding capacity will be high in these circumstances. These are mainly mediated by hepcidin enzyme from the liver. They modify the transport proteins at the intestine level, as well as in the blood, as well as at the tissue level. That explains why some of us may have encounter anemia, even if they had normal ferritin level in chronic inflammatory diseases and renal diseases. Epidemiology of iron deficiency or anemia is 8% in toddlers and adolescents, 12% in pregnant women, about similar a bit over in non-pregnant menstruating women. And it's a big problem in indigenous population. More than 50% of them, mainly women, are iron deficient. Causes for iron deficiency: inadequate intake, whether it's an absolute inadequacy or relative. Absolute inadequacy, as explained before, could be diet related, whether we are not taking enough iron in our diet, or relative, whether we are not maintaining the loss by our intake. And there's a bit of an overlap there as well. You can see there's some people have excessive loss. That again goes to relative as well. Malabsorption. Malabsorption could be due to several issues. One of the commoner problem that we may come across in developed world is a weight reduction surgery, like gastric bypass surgery. And in women with anyone with chronic inflammatory bowel disease, they will have less iron absorption. If they had surgery, bowel surgery for other reasons like malignancy, they will have reduced iron absorption. And chronic inflammatory disease, they may have normal iron absorption, normal iron intake. However, their transport mechanisms can be interfered, therefore their absorption can be slow. Functional iron deficiency anemia is one that typically explains good iron stores or good iron supply. However, the mobilization is slow because of interleukin 6 mediating through hepcidin interferes in the iron transport from the absorption site and the storage site to the erythropoiesis. There's about 3 to 4 gram iron we have in our body. Most of them are in the hemoglobin and some are in myoglobin. And only about 3 milligram that we transport in the transferrin. Iron is mainly absorbed in the terminal, in the duodenum or in jejunum. Heme iron is in the animal form absorbed better than non-heme iron. However, most of our iron requirement we get from the non-heme iron. Adult male and postmenopausal women will lose about 1 milligram iron a day. Women in the reproductive age will lose another further 1 milligram a day. Pregnant and breastfeeding mothers also will lose an additional 1 milligram daily. However, the absence of their menstrual cycles counterbalance for this loss. What are the causes for pregnant women to have iron deficiencies? Vegetarian diet, teen pregnancy, pregnancies that are too close together, twin pregnancy, pregnancy with existing iron deficiency anemia, in the background of menorrhagia or intestinal parasites, a low socioeconomy. What are the effects of anemia in the mother? Increasing tiredness, headaches, unable to concentrate at work or study. Most of our mothers will work up to about 36 weeks gestation currently. And if they have anemia in the background, they may not be able to do this until the end of the pregnancy. They may have to stop working earlier. And we may have to sometime admit them and to replace them with iron, whether it's in the parenteral form, that they can be having a normal life and normal work. Worsening or new onset of heart failure. This is a problem that we are increasingly finding, but we are not going to confuse this with cardiomyopathy in pregnancy. In pregnancy, cardiac output increases, heart rate increases, and the plasma volume relatively increases. And if we decrease the oxygen carrying capacity, we are putting more load on the heart, and that can increase the demand from the mother's maternal heart. And to the fetus, there's increased risk of IUGR, prematurity, mainly because of preterm delivery for any maternal or fetal complications. Iron deficiency anemia in who are not pregnant is mainly because of menorrhagia. And the next common cause is diet. And third common cause is intestinal absorption. As I said, most of our patients that I see are either chronic inflammatory bowel conditions, or whether they had weight reduction surgery, or smaller portion has got eating disorders. Menorrhagia causes, that's the main topic that I was going to talk today, is there's anovulatory menorrhagia. That is the commoner cause that we will see in our clinic. Who will have anovulatory menorrhagia? There's physiological states, either end of the reproductive age, women who are starting to menstruate, or women who are perimenopausal will not have a proper hypothalamic pituitary ovarian axis. Therefore, they don't have regular monthly cycles. They will have unopposed estrogen level in between the prolonged cycles that will increase the thickness of endometrial lining. And when they have one ovulation that triggers a cycle, they have to shed all this endometrium that causes a heavy and prolonged bleeding. PCOS is another pathological condition that causes anovulatory menorrhagia. Then abnormal uterine bleeding is another term for idiopathic bleeding in any other form of medicine. We used to call this dysfunctional uterine bleeding, and they found this name nomenclature is a bit offensive. Therefore, they changed the name to abnormal uterine bleeding. And fibroid is the third commonest cause, and adenomyosis is somewhat similar now in number of cases that we see as a cause for menorrhagia. How do we diagnose? History. Most women notoriously do think that they have, this is normal for them until they become iron deficient secondary to the menorrhagia and anemic, and then they reach their primary care physician. And when they diagnosed anemia, they go through the history and they find out. So quantifying is menstrual loss is difficult. Qualitatively or somewhat quantitatively, you can measure it, number of days of bleeding, number of pads they're using, and whether they are passing clots. And then secondary symptoms like anemia, symptoms of anemia, you may come to a diagnosis. Examination most of the time does not reveal anything. Most of the time you may see someone anemic by looking at their heart rate, they look pale, but you may not have any gynecological clues unless you have a large fibroid or adenomyosis in the examination to find a cause. Investigation, almost always I don't do anything other than a full blood count to diagnose anemia and an ultrasound to locate any localized cause. We may not need to do thyroid function test. That's not a routine test that used to be done in the past. We don't have to do coagulation profile that we used to routinely do in the past unless we suspect a person has thyroid disease, or unless we suspect on the history that person has a coagulatory problem. Exclusion for this is one that in a teenager who has a first period that is very heavy, that may be a first time you may be diagnosing a 1 milligram disease, then yes, do the coagulation profile. So how are we going to manage this? First, we have to control the loss, and then we replace the loss. Simple. So controlling the loss, like as common things, medical and surgical. The medical can be divided again into non-hormonal treatment and hormonal treatment. Mainstay of non-hormonal treatment that I would advise is tranexamic acid. We give 1 gram 3 times a day if they don't have any contraindications from the day 1 to the day 7 or day 5 of their periods. NSAID is somewhat less effective in terms of controlling the bleeding unless the menorrhagia is sort of mild to moderate, then they can control the bleeding. Hormonal treatment, the main hormone is progesterone. We treat with progesterone as a pill, progesterone as an implantable device. Progesterone as a pill is progesterone only pill. I can give a Premalute, but it's not an ideal drug to give long term. It is mostly given to control the emergency control of a blood loss. Long term, we either put them on a combined estrogen progesterone pill or Implanon or Mirena as an implantable device. Implanon is in the aspect of the upper arm for the doctors who doesn't practice general practice or gynecology, and it lasts for 3 years. Mirena is an intrauterine device. That's the same progesterone hormone that lasts for 5 years, and that works as contraception as well as control the pain symptoms from endometriosis. Surgical treatment can be more focalized treatment. Like if you find a myoma, you can remove the myoma as a reproductive conservation surgery that can reduce the amount of bleeding. And the myoma has to be more than 5 centimeter intramural in position or submucous position. Subserosal fibroid does not usually cause menorrhagia. Endometrial ablation and hysterectomy, more sort of permanent treatment. Endometrial ablation is very quick, can be done as a day procedure, lasts only about 30 minutes to do the procedure. They go home, they can get back to work after a week or 2. What we're doing essentially, we're burning the endometrial lining and replacing with the scar tissue. They shouldn't get pregnant. So this is a treatment for women who have completed their family and after have done a permanent sterilization or permanent conception. If they become pregnant, that can be dangerous to the woman, to their life and the pregnancy as well. Hysterectomies, again, like it's you can do it as a laparoscopic hysterectomy. You can do it as an open hysterectomy or vaginal hysterectomy. That is a complete one-stop treatment for the menorrhagia. However, again, it's one of the major surgeries. Therefore, it has got risks attached to the major surgery, and it is for women who have completed their family and they have tried the medical treatment and failed medical treatment. Normal daily intake for men is about 8 milligram in terms of replacing the loss. Menstruating women, we give about 18 milligram. Pregnant women will need about 30 milligram daily replacement. Blood donors and vegetarians are there, and I'm not going to go into that. And so what we have to do as practitioners, we have to advise first on diet and enriched diet. And as Malathi said, if someone is already anemic, that is not enough. Then we have to mainly first start with oral iron supplement. And if that doesn't work or in certain situation, then we go parenteral iron supplement. Heme iron in meat, pork, poultry, and non-heme iron, this we looked at already. And these are some of the products we looked at already. Parenteral iron at best meat, this is what we do. And most of the iron infusion that we give is for women who are low in iron and low in hemoglobin, and in their 3rd trimester, about 34 weeks. It's contraindicated in the 1st trimester. You can give in 2nd trimester, but we still try to give oral iron supplement. Towards the end, there's not enough time to replace. Therefore, 3rd trimester, we mainly move on to parenteral iron if someone still iron deficient, or if they tried oral iron and that they didn't achieve the required replacement. Ferric carboxymaltose is Ferinject. It's commonly that we use. We dilute it in 250 mils of normal saline given over 15 minutes. It costs about $300 an infusion. Iron polymaltose ferrosic, it's given as an inpatient. We mainly target the Ferinject because it's overall, it's a cost-effective measure for the health system to do that as an outpatient treatment in a short time. However, the patient will buy the medication when you buy Ferinject, when you have to admit and give, and you get a hospital bed admission cost, as well as the medication cost and the nursing cost. In my conclusion, I would say iron deficiency anemia is relatively more common in women of reproductive age. It is important to manage the loss, that is menorrhagia. It is important to optimize the ferritin and hemoglobin level in planning to conceive, planning pregnant women. Education on dietary intake is important, and we can choose where needed oral or parenteral iron supplement. And that's my references, not a big list. Any questions, I'm happy to answer at the end. Thank you. Sudeshan, to you.
Thanks, Anbu. Thank you very much for that wonderful presentation. And virtually we have run out of time, but we can have one or two burning questions. If there are any, please use the chat box or the Q&A. I can read it out to the speakers and they will be able to discuss your questions. Yeah. Can I ask a question, Anbu or Malathi, whether you could see? Okay, here we go. We have got a few questions. The first question is, Anbu, probably this is directed to you, I think. If a pregnant woman has only iron deficiency but normal hemoglobin, how do we manage?
If they're only iron deficient, we will check, we will replace them. And it depends on their level of deficiency and depends on the trimester. And we reassess the iron stores after 6 weeks to 12 weeks. And also it's important to identify the reason for the iron deficiency as well. If they're already having malabsorption, then it may not be ideal to try oral iron supplements.
Narmada, I'm sure you got the answer here. The second question, how frequently we can give IV iron transfusion? Some patient requires frequent transfusion. If there are any time frame, probably in between two transfusion, I think. Malathi?
Yeah, so mainly the IV infusion at one time, you can give 1,500 milligrams of iron at one infusion. And if more is needed, then it has to be after about 2 weeks. And another infusion can be given. And usually it maintains for up to about 3 to 4 months. And if they are continuing to have ongoing iron supplements, oral supplements, it will maintain, but otherwise it can, depending on the condition, it might go down.
Excellent. Thanks for that clarification, Malathi. All right, thank you so much for both of you for taking our request and giving a clear in-depth of knowledge to our viewers. And as a token of appreciation, we will send you a small gift, and now the viewers can see Anbalahan and the gift on the screen. And we will send it across to you, Andrew.
Thank you.
All right. Now, before we move on to the next item in the agenda, the CME was sponsored by a pharmaceutical company, and we will have a small commercial presentation. It will run as a video presentation. Now the screen will move on to that. It's coming. Thank you very much. So the other sponsors for the CME, Tactless Pathology, Vitaris pharmaceutical company, and TMP, the medical clinic. Thanks a lot for all the sponsors and to the presenters. And now we will move on to the next agenda. It's to hear a few words from one of our special guests, who is not an unfamiliar personality to us. That's no one other than our beloved and precious Professor Nadaraja Sriharan. I will say a few words about Professor Sriharan and his current involvement with medical field. Professor Sriharan is currently a senior consultant to medical academia and industry globally, and holds several visiting professorships across many universities globally. Formerly, he was the foundation professor and chairman of medicine at the Faculty of Medicine, University of Jaffna. And he held a position as senior vice president and European medical director for one of the largest pharmaceutical companies, GlaxoSmithKline. And Professor Sriharan led teams that developed new medicines across multiple areas, including diabetes, heart failure, and Parkinson's disease. He has functioned as a board of examiners in medicine at the Royal College of Physicians, London, and worked as advisor, mentor, patron across many universities in developing their curriculum or in revising their curriculum. Currently, with all his clinical and medical industry commitments, he is the patron for our sister charity, the UK chapter. The JMFOA UK chapter charity is patron is Professor Sriharan. Let's listen a few words from one of the genius in the current medical arena. Professor Sriharan, over to you, sir.
Hello, everyone. Can you hear me?
We can hear you very clearly, sir.
Yeah, I'm actually speaking from Sydney in Australia. I'm visiting Australia at the moment. And good evening, everyone. Thank you for granting me this privilege of attending the AGM and saying a few words. It's always a pleasure to be involved in activities related to the Jaffna faculty or the Jaffna alumni, faculty alumni. It's something that is very close to my heart. And it is also wonderful as I travel around the world, whether it's the US, UK, Canada, or here in Australia, to see so many of the graduates over the last 40-year period of the Jaffna medical faculty doing so well in many areas, in all the areas that encompass medicine, as in academic medicine, as professors, as specialists, subspecialists, general practitioners, and even entrepreneurs running healthcare systems around the world. So all of you do proud by the Jaffna faculty. So I want to thank you and congratulate you. And of course, listening today to the two speakers that exemplified that, both Malathi, whom I know very well, and Anbalagan, whom I don't have the privilege of meeting because he joined the faculty after I left. Excellent presentation, very comprehensive. Even my aging brain, I learned a lot of things and refreshed my brain. And importantly, to show that even conditions like iron deficiency anemia are global diseases. They have high prevalence, they have high morbidity, and it's very important that we have to take these disorders very seriously and try and identify and treat them. Listening to the presentation, it also I recollected my own interest in the red cells. Some of you might have heard me say this, but the red cells are very unique cells in the body. They are the only cells which don't have a nucleus. If you leave the platelets aside, which are cytoplasmic remnants, they don't have a nucleus. And therefore, they don't have genes and genetic materials. And they don't have what has been called by geneticists as selfish genes. It's the genes that drive us. A lot of wonderful things that we do, and also not so wonderful things that we do. Because the genes are only interested in survival. They want to disseminate widely, and therefore they drive the survival mechanism in all of us, right? Survival at whatever cost. But the red cells are very different because they don't have genes. They are real role models for selfless service. You know, they come into being, you know, enter the blood, day in, day out, they carry oxygen to every other cell in the body. And when the 120 days are over, they don't look for rewards or anything. With a smile on their face, they leave the world, right? Because they don't have genes, they are not survivors, and they are the ideal role models for all of us in terms of doing selfless service. And I, as your chairperson, Sudeshan said, I also want to thank and show my appreciation for many of the healthcare professionals, including those from the Jaffna faculty who have borne the brunt of looking after the patients in the world, the population of the world. And that is selfless service. And ultimately, like the red cells, when we leave this world, we are not judged on the professorships we hold or the material benefits that we have accumulated, but have we been contributors to the world and consumers of the world. And the red cells are therefore ideal role models to all of us, and we must take a leaf from the life of the red cells. And finally, same thing with COVID. You know, the COVID pandemic has created havoc, you know, affected all our lives. We lost a lot of loved ones and a lot of diseases, mental health issues, and economic losses to a lot of young people. But we also must learn from the lessons of the pandemic. And I hope the post-COVID world, both in terms of the world at large and in our own individual lives, that we learn from the pandemic, that it has sent us some never fear the virus, but respect the virus. You know, the virus doesn't want to kill us because it has no evolutionary advantage of killing its host. right? That happens due to other reasons, lack of immune response or hyperimmune responses. The virus wants to transmit itself. That's all it wants to do to survive. And therefore, we must take the non-pharmaceutical interventions very seriously in terms of distancing ourselves from the virus. And I hope eventually, I gave a talk at the JMFOA at the beginning of the pandemic. It's certain the pandemic will end. The only thing we don't know when and in what form. And I hope the Omicron is the beginning of the end. I don't think we have got to that point as yet. So we have to be careful and learn from the virus, because it has also given us a very good signal of taking the pedal off the accelerator. That sometimes the world becomes, it's like driving a good car. We have to get the right balance between pressing the accelerator and pressing the brake. And it has given us some time to recollect, right? Contemplate and look at our lives, spend some time with our loved ones. And therefore, I hope some of the lessons we have learned, both in terms of delivery of healthcare system, using technologies, and looking at our own lives, some lessons from the pandemic will make the world a better place, and that we address some of the terrible inequalities that we have around the world. So with that, I want to thank you all once again and congratulate the JMFA Australia. I know you do a lot of work. I'm aware, and Jaffna running the Well Clinic or Well-being Clinic and other things that you have done through various organizations. And I noticed Dr. Mohan is here, and very nice to also see Jaya, Professor Jaya Somasundera, for whom I have a lot of respect. He has done some enormous work in supporting the faculty and looking after our population, our communities with their psychosocial issues. So it's great to be here, and I thank you for granting me this privilege.
Thank you so much, Prof. Thanks for those words of wisdom. Not many of us live our life like the red blood cells. We try to be white blood cells and try to generate benefits from what we learn and earn. Okay. Once again, before I wrap up the CME session, I would like to say our sincere gratitude and thanks to our regular sponsors. This year's platinum sponsor was Tungabi Medical Practice, and the gold sponsors were Douglas Pathology, Vitaris, and IVF Australia. Thanks a lot for the sponsors. And now we will move on to the next item in the agenda. As Prof. Sriharan said, not many live their life like red blood cells, but we have a few in our community who have done that, and we all have had the privilege and opportunity to live in the era they are living, or we had an opportunity to mingle with them in various occasions. So this year's committee decided to honor them by awarding them a memento plaque. So originally this was planned as a face-to-face occasion, and Professor Sriharan would have been handing over these memento plaques, but we are going to do that in a virtual fashion today. So I will move on to that item now. And if you look in your career or in your life, success is never achieved or reached without hard work, commitment, and also failures along the path. The recipients of the awards here today have worked for their passion over many and many years, and they continue to do so. Their distinctive service beyond their bread and butter specialty has helped many underprivileged people in our community, both locally and internationally. We have got few people receiving this honor from JMFOA Australia today. I will first start with a very well-known personality to all of us, Professor Jaya Somasundera, who doesn't require any introduction to you all. I can see Prof here. Prof has been in the field of psychiatry for more than 40 years. He has served our community during the toughest time in our history. He's a researcher, he's a writer, as you all know, but professed a special interest in post-war or post-natural disaster related psychological effects. He was the primary author of many research publications and books. To name a few, you all would have heard or read about Scarred Minds, which is the psychological impact of war on Sri Lankan Tamils. And he was the co-author of the book, Broken Palmyra, which I read about 5 times, the Tamil crisis, about the Tamil crisis in Sri Lanka. Professor Somasundera is a fellow of the Royal College of Psychiatrists, Royal Australian and New Zealand College of Psychiatrists, and the Sri Lanka College of Psychiatrists. Currently, he is on an extended sabbatical leave in Australia, and he was working as a consultant psychiatrist in Adelaide, and now moved to Hervey Bay, and he works as a consultant psychiatrist in White Bay Mental Health Services in Hervey Bay in Queensland. As many of you may be aware, that Professor Jaya Somasunderam was the instrumental or the person behind the initiation of the Wellbeing Center at the University of Jaffna in 2018 by JMFOA Australia in collaboration with the University of Jaffna. The Wellbeing Center undertakes the challenging task of supporting the psychological needs of the university students and staff. It has been evolving and getting modified and improving day by day, but yet to reach Prof's dreams. And JMFA Australia is committed to improve that and support the students in future as well. JMFA Australia is very proud in honoring him for his outstanding contribution to our community. So now you could see the plaque, the memento plaque, which we are awarding to Prof. I will read what's written on the memento plaque. Dear Professor Jaya Somasunderam, in appreciation of your knowledge, wisdom, and compassion towards the well-being of our community. Thank you very much. And this is virtually presented to you by Professor Sriharan. Thank you, sir. All right, next. I'll move on to the next person who is receiving the award. That's Professor Yasoda Shannon. I can proudly say that Yaso is one of our own product. She's from the Jaffna Medical Faculty's 4th batch. She graduated in 1987 and then moved to USA for her advanced training and completed her MD in medical oncology. Later, she migrated to Australia and worked with Queensland Health as a medical oncologist. She's an eminent physician and promoted to Professor of Medicine in 2021. And Yaso is currently the Director of Medical Oncology and the Clinical Subdean, Gold Coast University Hospital. She's a great academic and a researcher. She owns hundreds of publications locally and internationally. Apart from her academic and professional career and achievements, Yaso has a great passion in helping and supporting our community back in Sri Lanka. She has worked as a volunteer, physician, teacher, mentor with many charitable organizations in Sri Lanka. She has helped many junior doctors to undertake the advanced training in a unit to complete their fellowship and move on as consultants in Sri Lanka. Abhayam organization is one of the charitable organizations which functions around Sri Lanka and both Jaso and Professor Shanmugaraja, both of them, both husband and wife, are heavily involved in that charity work. More than anything, Jaso was the president of JMFOA Australia chapter in 2017 and was an active member of the executive committee for many years. To be honest, she has been a trendsetter for JMFOA Australia's current approach towards conducting a CME, how to arrange an annual dinner, and also how to and when to undertake large-scale projects. We were doing very small-scale projects before Yasoda took over. Since then, we have gone on to put our steps into projects which were $1 million. JMFOA Australia is very proud in honoring one of our own multi-talented member. Yes, sir. Your memento plaque is just next to you on the screen. I'm sure we will see Professor Sriharan as well. Right, Professor Sriharan has awarded that to you. And what's written on the plaque is your hard work and dedication towards your passion has paid off. You are an asset to our community. The satisfaction of doing your best is a great reward. Well done, Jaya. Thank you very much. We will move on to the next award presentation. It's another well-known personality in our community, Dr. Vairamuthu Menamohan. Dr. Menamohan is a senior cardiologist in Sydney. He graduated from Peradeniya University and had his advanced training in cardiology in UK. To add to his excellence, he has worked as the cardiologist to His Majesty of Royal Family of Brunei in 1990s. Later, he migrated to Australia in 1993 and started working as a consultant cardiologist. As many of you are aware, Dr. Menamohan is one of the founders of Australian Medical AIDS Foundation, which is a charitable organization functions in Australia, helping the war-ravaged community in Sri Lanka for decades. Even when I was a medical student, I know the name. AMAF has donated something to the hospital. Dr. Menamohan is the current chairman of the New South Wales chapter of Australian Medical Aid Foundation. He was the past president of Tamil Mandram and Sydney Tamil Resource Centre. He also functioned as the chairperson of the Australian Tamil Electoral Lobby. As you could see, he functions like a red blood cell, as Professor Sriharan said. His contribution to our community is outstanding and impeccable. JMFOA Australia is very proud in honoring Dr. Menamohan. Now you will see Dr. Menamohan and the memento plaque, which is awarded to him by Professor Sriharan.
Thank you.
Thank you, Dr. Menamohan. And what's written on the plaque is in appreciation of your commitment and distinctive service to our community. Thank you very much.
Thank you.
We moved on to our last awarding to another professor, so the Associate Professor Jaya Mohan. Unfortunately, due to some unexpected personal reasons, he was unable to be present here personally. Associate Professor Jaya Mohan is a senior radiation oncologist at Westmead Hospital and senior lecturer at University of Sydney. Apart from his professional excellence, his passion towards creative art is immense. Among the Tamil community in Australia, is a very pronounced and respected writer, director, and producer of many stage dramas and short films. Many of you would be aware of his stage dramas such as Laughing or Laughing and Sirikalam Wangu, which reached out to the community with great success. His recent short films such as Oru Cappuccino Kadal and Boomerang were YouTube hits, as you all aware. Professor Jaya Mohan also runs a charitable organization in Sri Lanka, which is called Sivanarul Foundation, which enormously support the people in need in northern part of Sri Lanka. JMFOA Australia is again very much proud in honoring Professor Jaya Mohan, another multi-talented personality in our community. Now you will see Professor Jaya Mohan's photo and the memento plaque which we are awarding to him. What's written on the plaque is in appreciation, it's not Manamohan's photo, it's my photo is there, sorry. In appreciation of your commitment and distinctive service to our community. Thank you very much. That concludes the awards for 2021 from the JMFOA Australia.